these are the objectives of today's talk. Just very briefly to look at risks and causes behind some of these delays in type 2 or starting insulin in type 2. It's not going to be an exhaustive review of that because there's a lot of research on complications versus control. Really, it's more about learning how practice and education has been changed, from our perspective, and I think it's an ongoing process. So it isn't something that just changed and now we're appreciating the benefit of that. We've still got a ways to go, and I think it's raised actually some more questions than perhaps providing some answers. But the interesting thing is to see how we're doing things like what you're going to see, what we've done here in this research project, kind of on a daily basis. But it was formalized in a research project. But the power of that is actually quite significant when you do go that extra step and actually write about it and share it. You'd be surprised how much of our knowledge we gain on the job is actually perhaps not appreciated maybe until it becomes a bit more visible. So the outcome here for us primarily was an approach that doesn't really involve a lot of complex tools. It's really not flip charts and complex algorithms. It's really just an engagement. So hopefully that comes out to be fairly clear. So what do we know coming into this project? So we know that clinical inertia exists with respect to initiating appropriate insulin therapy. That's not just initiating but intensifying as well. I've got a slide on clinical inertia if you guys haven't heard that, but I think it's probably fairly straightforward. There are a lot of misconceptions and realities as well regarding insulin. We as diabetes educators, we encounter that on a daily basis as patients come in to start insulin, and we see that change just in the dialogue and in a meeting. So it's quite fascinating to see that there's something that's not static. It's a very fluid perspective that can be modified, and so that was kind of where this thing began. And this is the psychological insulin resistance is a commonly researched phenomenon as well, and Polanski is the fellow who did a lot of work on that. And we know that because of that, there's this duration of prolonged, elevated glucose levels that is causing harm not only physically but emotionally too. So there are a few issues around inertia. It's not just, should be happening earlier, but it's no big deal. There's a consequence to that. So this is, where it all began for me. I was given this article by Dr. Stuart Harris, who was an author of, I think, the 2003 Clinical Practice Guidelines in Diabetes Canada, formerly called Canadian Diabetes Association. So one of the local representatives for an insulin company shared this article with me, and he did a study in Ontario involving 109 doctors, and each of them had sort of, their first 10 patients that were starting on insulin involved in this study. So what he found out essentially was that people were living with diabetes for about 9 years, a little over 9 years, and the A1C at the initiation of when the insulin was started was around 9.5%. That was the mean. The thing that really struck me was that the complications that were evident at the time they started insulin was around 74%. So that's mainly microvascular disease. We have neuropathy, microalbuminuria, those kind of things, retinopathy. And after 3 years, or 3.8 years, at the end of his study, that incidence or prevalence actually of complications went from 74 to 94%. So basically, things got worse. Complications didn't just stop from happening, and insulin was being initiated too late. So that was his real focus. And I thought, I wonder what's happening in Victoria. So this is sort of the definition of clinical inertia. I pulled it from his paper. And there are three problems. One is the overestimation of the care we provide. So that means, geez, you come to our door, we must be doing the right thing, and we just assume that you're going to be okay, even if we don't really provide any quality to the visit. That might be an over-exaggeration. But there's also some soft reasons that we have to avoid adding something or doing the right thing. And that's what we're going to explore a little later on. But they could be rather vague notions, and we did try to extract that from some of these patients in our study. But they're quite real and quite powerful, actually. And there's, again, some lack of education, training, and organization of practice, so we've tried to address that as well. But I think those three things pretty much capture the reason that clinical inertia does exist. So this is what I've found, and this was after Harris's study was published. So every couple of years I do this. I kind of casually gather up the first 20 referrals that come through our door, and so it's just a random kind of assessment of, what's the average A1C, how many years have they been living with diabetes. Some of the information is not always complete, so these aren't like super accurate numbers, but they're pretty consistent. So back in first one was 2012. I did this 2 years after I kind of encountered Harris's article. We see that our A1C was 9.3, so that's fairly similar out of 21 patients. We've got a bit of a mix of GPs and endocrinologists sending patients our way to start insulin, and there's just a breakdown of kind of which insulin they chose. I was kind of curious about that. Lantus was sort of fairly new at the time, and they were prescribing that in a big way. Later on, 2 years later, A1C got a little worse, but again, these are small numbers, so that's not really clinically significant perhaps, but it's not heading in the right direction. So I've done this every 2 years or so, and it's not getting better. We're seeing actually an increase in acuity, probably speaks to a number of other things, increasing population, not increased number of people doing the job, so it might be hard to keep up. So after I presented this at our local island-wide meeting with the diabetes centers, our manager, now director, manager at the time, now director, said, why don't you formalize this? So that's what we did. We put this money together, and that's where the research department got involved, and we were awarded the seed grant. So that was the title of that project that kind of took about a year to get going after we got it through all the hurdles. So we involved eight diabetes centers. What we're really looking for was a pre- and post-perspective of a patient as they showed up, referred to start insulin, and returned later to let us know how they now felt about insulin or thought about insulin. So we were looking at some basic things, what was the A1C at initiation, how long were they actually speaking to their provider about insulin, like, geez, you should go on insulin, and there's a bit of a negotiation period going on. Looking primarily at their concerns before and after. Some of our efforts were trying to look at maybe perhaps geographical differences on the island, such as, what's happening up island versus in Victoria. The numbers aren't great, so it's not a great quantitative study for that. It's really more looking at understanding here. So unfortunately, those numbers didn't really pan out, although there's definitely a direction that they're in the smaller, more remote communities, the A1Cs aren't lower at initiation, but that's, again, the numbers are so small, I can't really make a hard conclusion on that one. That's where the sites are, still are, so that's kind of where we all are existing and doing our jobs to various degrees of hours, I suppose, and clinic size. So this was just jumping into it, the A1C scatter plot of the 73 patients that we gathered during this study. Now, the thing I didn't really mention at all was at the time of this insulin initiation study, there was a new drug on the market that was very effective at controlling glucose through the kidney mechanism. And all companies involved, there was 3 pharmaceutical companies involved that were giving out this medication for free. We had these sample cards, and at that time, it was really delaying the initiation of insulin further. So it actually took us almost, I think it was a good half a year to get 20 patients in our clinic at the Jubilee to into this trial. The end of 2016, I think it was, those cards came to completion, so the companies were no longer giving that medication out for free. I had 20 insulin starts in 1 month when that ended. So it was just unfortunate that our recruitment took a little longer than it normally would have. And I think for Up Island it may have been similar. So it was drawn out a little bit. But because we're looking at understanding here, it wasn't really about having numbers in a very short period of time or a lot of numbers. It's really more about gathering enough perspectives out there to saturate the point. So anyway, what you see here is a scatter plot, and the red dot in the middle is your mean. So what that shows us, and I didn't think of that when I looked at Harris's trial, was, yeah, he's got this 9.5 mean, but what's to the right and what's to the left? There actually is a fair bit of stuff that's actually working pretty well, and that really didn't think about. We just thought, everyone's a train wreck out there, but they're not. But what it does also mask is the stuff on the right. So there is a lot of disastrous control out there and very significant delays, and that's what we need to focus on. I think we should celebrate the challenge, the successes. Actually, I was going to say challenges, in that there are some things that are happening appropriately. There's informed people out there, both physicians, clients, and this does not seem to be a big issue. But there's a big group that struggle with that, or they have misinformation, or they have lack of access to services, and I think that's what we're going to focus on. So anyway, hopefully that we will get somewhere with that. So this is just a bit of the medication assortment that people came to. Those numbers on the bottom are percents. Those are numbers in the study. So metformin, obviously drug number one, and then there's a variety of other things. The SGLT2s, you can see how that dropped right off because they were not on that drug, and that's why they were starting insulin. Often if they were started that drug, that would delay insulin even some more years. So these are the complications, again, numbers of people reporting these complications, and this was, picked up from the conversation or the charts or the lab work that the clinicians had at the time. So you can see they're significant. There's, 15 people identifying renal complications and another 15 with either stroke or heart disease history. Neuropathy was, a little over 10 there. So there were microvascular concerns, as Harris did identify in the population in Ontario. So the years above target was a little sketchy, hard to gather sometimes. People show up, we don't have that always on the referral, so, it was kind of like a conversation between the client and the nurse who was doing the questionnaire. But it was picked up, at least in the study, about 2.7 years above target. So that target is also individualized, so some nurse clinician might think that the target might be 8, and others might think it's 6.5. Again, that should be drawn from where that patient is at, age, comorbidities, and that type of thing. But that was, I think, a reasonably accurate clinical guess at best. So this one here, for example, and this is kind of an example of how these A1Cs weren't always meaningful. They're not always up to date. A lot of patients aren't getting A1Cs routinely done. So this particular fellow who had an A1C of 8 reported had blood sugars in the 18 to 23 millimole range at the time. So I hope I'm speaking to people who know what that actually means, but that's really high. So many people are deteriorating quite quickly before they actually show up to start on insulin. So that A1C could have been 6 months old, but lots can happen in that short of time. So this was sort of what was reported in the months of discussion with your physician. So when you said, well, how long have you been sort of hearing that you should be starting on insulin? There's a huge standard deviation on this one. But on average, it's about a year. Those are in months. But you can see that all the blue dots clustered on the left. That means that physicians are saying it's time to go on insulin. They're like, okay. So a good part of them are actually starting soon after that discussion. So these are a bit clipped off because these are actually pulled right out of REDCap when I've just kind of made a screenshot of some of these graphs. But the one on the left is self-management failure. So these are reasons. Basically, the question was like, what are your initial thoughts about being on insulin or having to go on insulin? So you can see that there's the biggest bar that's highest there is the general reluctance. These are just sort of vague interpretations like, well, I just don't want to do it. I'm not sure why. I haven't really thought about it, but it's just kind of a unspecified reluctance. You can see weight gain, hypoglycemia, not really a big issue. People really either not aware of it or it's just not something they're concerned about, probably more likely not aware that that's an issue. But it is really some degree of a self-management failure on the left. The dependence on insulin would be the next one. So that was not super common, but 10 or 11 people did identify that or more. That if I go on insulin, that means I didn't do a good enough job. I should have tried harder. There was a bit of a needle fear. A few people did identify that I don't want to inject myself with a needle. They really didn't know what the needles actually look like. Pain wasn't really significant because they hadn't tried it. Inconvenience, there was a number of people thinking that it was quite complicated, that traveling, having to do insulin once you're on it, you're never off it, and it's just a big hassle. They thought it was quite complicated. I mean, some people thought their diabetes was now worse if they had to go on insulin. And the other interesting one was quite a few people, more than half of them, were actually aware of the benefits of insulin. So it wasn't that they were all negative about it. There was actually many people who thought, I want to go on insulin because I know it's going to work. And then there's a lot of other vague things that I couldn't really put into one category, too. So what was actually the reason they got started? So what was the trigger for you, or why are you finally here? What really made this happen for you? High blood sugar, so 40 people out of 73 actually were concerned about their high blood sugars. Some people felt unwell. The doctor order there, quite significant. It was, well, the physician told me to, and so that was the reason for them to get started. So don't underestimate the power of that. If there's any physicians watching or here, there's a lot of power you have in that suggestion or direction that you have with patients, believe it or not. Even though there might be a significant perspective of non-compliance out there, you do have a lot of credibility still. Anyway, complications was one too. Some people were aware that they'd have the onset of complications, so that was a motivator for them to get on insulin. Many of them, over 40 people out of the 73, realized that the medications aren't working. And again, almost equally that number are realizing that there's going to be some benefit to starting insulin. So it wasn't all negative. So it wasn't all patient-driven inertia, obviously. Sometimes family caregivers were sort of involved in saying, you really need to get on insulin. A few people were hoping to get rid of some of their pills, and then a few people realized, actually quite a few, realized that, it's not actually that complicated. I kind of know what it looks like. So the main one, again, there was the big driving factor, and those are the ones that were kind of the most significant. So this was kind of an interesting question. It's based on out of a 1 to 10 scale, how do you feel about starting insulin? So I thought I'd throw a qualitative question in there, and kind of in the middle. But this was kind of poorly executed on our part. I think what happened was sometimes these questionnaires were given at the very end of the insulin education session with the client, and then the clinician was asking the patient, so how do you feel about insulin? Well, their perspective changed from the time they sat down to the end, and they're like, oh, well, it's great. So it kind of messed up a lot of correlation analysis stuff. But anyway, so here what you see is that a good number of people were and that scale on the bottom had to, convert into 100, but it's basically a 10 scale. So basically the mid about starting was 5 out of 10, but half of them were more negative and quite a few fairly positive. That line on the left, it's 1, so that's where a lot of them were sitting. Actually, a lot of them they rated it at 0. So I said 1 to 10, how do you feel about insulin? 0. It's not really on the scale, but so I had to move them up a little bit, so maybe I should have left that. But anyway, that just shows the spread of the perspective. But again, not super accurate in terms of capturing it at the right time. So then this is the how do you feel after. So this is the question posed after a person came back a month or were contacted within a month or two. You can see that shifted forward quite a bit or to the right. So, an 8 out of 10 median, which is quite significant. There's a few stragglers there still on the left, and I'll explore a few of those as well. So then I thought, okay, what about the people who actually were negative? So the ones under 5. So I just pulled that part out of REDCap and looked at them on the left. So those are all the ones that were less than 5, and they had a mean of 2. So this was an interesting group, because then when they came back, we asked them how they feel, and they went to a mean of 8. So that's a huge shift. So the most reluctant actually became fairly positive about insulin. Those few, the one on the far left was a woman whose brother was a drug addict, and she still had this association of addictions and injections. And in that month, she hadn't come to terms with that, I think. So that was an opportunity for some more work, some counseling, but still feeling fairly traumatized by the whole thing. And that certainly was an issue. The other two were actually very high blood sugar, or they had very high blood sugars at the time of insulin initiation, and started at ridiculously low doses, like 5 units of Lantus for an A1C over 12%. That patient was like, this stuff doesn't work, maybe I'll come back and try it again another time. So I don't know what happened to those patients, because we can't just go back and look, but I would say that if we miss that, we're not doing our job. So that's a conversation that we need to have as clinicians to say, we're sorry about that, and let's try to do this properly next time, or talk about how insulin can be titrated. So that was those experiences. So I think that's why they stayed rather negative. It was really ineffectiveness of treatment or trauma, which is certainly popular in some populations and communities. So here's just some examples of the dialogue. I think we're doing okay for time still. Yeah. Sort of before and after. So on the left, someone was quite positive up front. They had, an experience with a friend who had great success with insulin, so they came primed to start on insulin. And then afterwards, I don't know why it's not offered to people at the same time as pills, even with type 2. And actually, they've done studies on that. They've actually done a trial called the Origin trial that looked at insulin initiation early on. Didn't need to stay on insulin. It actually put people into remission. So sometimes that's an argument to help people understand that you can use it up front. But it's not always the best treatment up front, because we're dealing with insulin resistance too, and you don't just want to add insulin to everything. But for some it is appropriate. The other one, this is a client who actually, or a participant, that's the right word, who actually came to the Jubilee. And I remember hearing the conversation. Insulin is a swear word. If on insulin it's all downhill, I'm on my last leg. So that was a perspective of a client. I actually rated that a 6 out of 10. I would have given that a lower number if that was my perspective. But when that person came back, I'm not afraid of it. It's a hormone I need. A huge shift in perspective. That's just some examples there. Some more: crossing the line of no return, failure with looking at after my diabetes, before, and then the same person coming back. It's not the end of the world like I thought. I'm not afraid of it anymore. Rated it as a 7. So modest shift, but still moving forward on the attitude. This is one I had actually. A fellow said, he was really concerned about weight gain and traveling, and often people do gain a wee bit of weight with better control or with lowering that A1C, but this fellow did not. He felt better, moved more, ate better. He actually had no weight change, slept better, and he had no problem traveling with it. So he just thought, wow, this is just amazing. So these are things that were just revealed, and we're like, we see this all the time, and what. So anyway, it was kind of enlightening. Just some more things. What's changed in your perspective? This woman said, my brother said he would rather die than take insulin, and she now thought she might be instrumental in helping him look at that as an option therapy. She went from a 2 to a 9 pre-post perspective. Very common one. It's not as painful, not as much clutter, not that difficult. So again, moving forward quite a lot just with knowing what it looks like and trying that out. And many times we hear this, almost every time. If I knew how good I was going to feel, I would have started sooner. This question about, what would you have done or what would have helped happen? You moved to insulin earlier. Is a difficult question to ask, because I think when a patient's been sitting with years of diabetes and they have the onset of complications, and you ask them, well, geez, if you would have known how easy it was. I think it's almost a traumatizing question to ask. So we didn't get a lot of response on that one. I think it was a bit of a sensitive question, actually. I didn't really anticipate that. And many people want to avoid it as long as they can. And this one fellow just loved it. It's amazing to hear people come back and say, I love it. Like, you would not think they would ever say that, especially when you ask newly diagnosed people with diabetes, are you looking forward to going on insulin? They never say yes. That's for sure. All right. So what would have helped us was that question that was difficult, and some people were able to answer that fairly easily. If they would have known then what I know now, it's the unknown that was the barrier. So, again, a huge shift towards a more positive perspective of something that's haunting them for years. Knowing there are limits to the diet. Many people struggle. They're trying to eat better, less, be more active, and this is work. They're really putting a lot of effort into that. That breeds like shame and blame, and feeling that they're the A1C is still at 9% and they can't fix that with a diet. They finally think, okay, let's try insulin, and I think it takes a huge emotional burden away. So it's quite interesting to see that happen. And this is a woman up island. I remember looking at this report, and she's an Indigenous woman, and she said if she trusts and likes the person, she will pay attention. So very important in your dialogue with clients to focus on that, and that was what actually allowed her to move forward too. And again, going from a 2 to an 8 out of 10 on that rating of how she felt about insulin. And then just being able to have spoken to someone who knows about insulin would have helped. So sometimes patients aren't encountering the right person at the right time. They're going into the physician office, they've got 5 minutes, and that topic might come up. It's not like the physician wouldn't know about insulin, but it's having the time for that, and that's very challenging in our medical models that are fee-for-service, for example, to do things, in a more complex way when you have a limited time. And there's no delay. This was an interesting one, which kind of thought, okay, there's a clinical inertia on the physician part. My doctor got me on it right away. A1C at 12.2%. So it was like, okay, you're at 12%. Let's get you on insulin. Well, what happened before that? I don't know, and we don't know. Like, did the person not see the physician? Don't know. Anyway, so moving on. This is kind of really the guiding philosophy for me, and this was kind of my initial experience with research when I did my master's, was this sort of perspective. So really what it is, it's really the appreciation that each of us, client, physician, whatever you want to call that, has a certain perspective. So that's your horizon of understanding or knowledge. So that means from your viewpoint, you can see and understand a certain thing. And as you encounter another in a conversation, there's a fusion of those horizons. So that's where understanding comes from. So it's just a perspective or a philosophy of understanding how we understand things. So you throw things out like objective perspectives and absolute knowledge and that kind of thing, and you really try to let some of that stuff go and see what emerges from that engagement. And so really that's the idea of having that open dialogue with someone too. You've got a question at hand, and let that sort of take shape in the room. And that does happen at every session we have with a client. And this is kind of what their horizon might look like on the left. They have these ideas about, their medications, the complications, the fear and the despair, the trauma. It's many, many things. And actually just reviewing those things, those studies that I did, was mildly traumatizing because of that shared distress that is so evident. And then our perspective is often, the medical model, maybe perhaps, and the numbers and the guidelines and all that kind of hard stuff that drives what we think we need to do. But when you bring those two perspectives together and you can translate that to an individual, there's a new understanding that emerges out of that. And it isn't that you've changed your medical model perspective, but you've actually appreciated how that matters to the person that you've got across the table from you. So it kind of goes down to the basics. This kind of stuff, if anyone's taken like Helping Relationships 101. And this is just, we've done insulin here as a topic, but when we see people on medications, whether it's blood pressure, cholesterol, oral medications for diabetes, there's a reason they're not taking their medication sometimes. There is always a reason, just have to figure out what it is. But if you can explore a little bit about what's going on for you with that. If you've got metformin, which is a common medication used in diabetes, commonly also causing gastrointestinal upset, if people are having diarrhea every time they take that, they're not going to take that medication when they go out. So then they don't take the medication, then the next day they do, and then because they increase the dose very quickly, they have more diarrhea, so it just gets worse. But you have to understand their concern, so you have to ask the right question, because it will affect their behavior. And it's the same with insulin. So if they've got very negative perspectives on insulin and you don't unravel those, you're not going to change their thoughts about it, and they're going to not be compliant or adherent to the therapies. So I just sort of pulled this out of my hat, basically, and it's about, something about emotions and empathy, I suppose. But it's just an acronym here or whatever. Focus on your patient. So that's probably the biggest thing we've learned, and I think we do that to most degrees, but it was a bit of a reminder that you have to forget your agenda for a while, at least a little while, to understand, like I won't even bring out the insulin equipment or the stuff that I want to have prepared when I see that client. I sit down with them first, find out who they are, what their concerns, and I may not even expect they will go on insulin, but I do hope they will, and usually that happens. So the emotions is huge. You've got to address that. And for some people it's very difficult. I had a man in the room and I said, well, so do you have any concerns about insulin? And that's not the right way to ask the question, because he said, no. I didn't know what to say. I thought, oh. So I kind of sat there quiet for a while. And then he finally said, I just don't want my pancreas to stop working. So had I not left that space in the room, he probably wouldn't have said that, but it wasn't planned. It was just because I didn't know what else to say. But sometimes you'll be surprised. So for him, it was like, oh, if I go on insulin, my pancreas is going to give up. It's not like that at all. So once he got that clarified, which wasn't difficult, he was like, oh, great, let's get started. So had I not sorted that out, he probably wouldn't have wanted to stay on insulin. He would have hoped to get off, and maybe he would have got off and not continued later on. So you've got to have some empathy, or at least the ability to fake it. That does help a lot. And listen to your patient. So key findings, really, we found that the A1C at initiation was consistent, mostly worse than other studies that were reported. I don't know why that is, if it was because other formal studies were looking at recruiting people and they were, not the worst patients. I don't know. But typically I don't think I've seen anything higher than 9.8 or 9.7, some UK studies, but Harris's was pretty much on the mark with a 9.5. But really the mean does hide a lot of things that are happening properly out there, but it also hides a lot of the real disasters too. We know that psychological resistance is playing a role in this delay. We know that many physicians are trying to get patients on insulin at the right time, but patients have some ideas about it that is preventing that from happening. This is something I found just most profound, is this distress, this patient trauma that is persistent in the anticipation of having to go on insulin. But it's not only that. I had a fellow who progressed. He was a late onset type 1 in his 40s, actually. And he had gone from oral medications to insulin within a few months, and then had to intensify the insulin shortly after that. And he came in and he said, well, I've got twins. They're 4 years of age. And I said, wow, you started late. He's 40 or something. But anyway, he was really quite concerned. So I said, well, you've been on insulin now for a few months. What do you think about that? He goes, well, my numbers are better, but now I'm concerned about all the complications that I'm going to get because I've got this young family. And I said, well, I don't quite understand. Your blood sugars were high, but now they're good. You're on insulin. And he said, well, no, I know when you're on insulin, people have more complications. So he had this association that complications and insulin was kind of related, not thinking that, well, why would you give insulin to somebody to get complications? It didn't quite figure that out. But when he realized that now that his blood sugars were well controlled, he's much less likely to have complications, he was in tears. It was quite profound. So it's not only the beginning of insulin, it's ongoing. So you still have to have that question along the way. Like, how are you feeling about that? What are your thoughts about that? You're going to still unravel these psychological distress issues at any point in the game. It's not just prior to the starting of something. So those are the kind of conversations we need to have. So these were sort of the practice support strategies that are emerging out of this. We needed to enhance communication between people and diabetes with healthcare providers. We have the luxury of having a fair bit of time with clients in our center when they come in. We have 30 to 45 minutes, which is very helpful. Most times we can get at this stuff and address it. But if you're in an environment where you have 5 or 10 minutes, you have to be pretty clever and ask the right question. But it is possible. I had a woman come in and she said, when she was starting insulin, she said to me, her doctor asked her, well, what are your concerns about insulin? I'm like, beautiful, that's great. That's the question that they could ask, because she could share what they were, and the physician could address those, hopefully mostly solve them, and she was fine. So it's not really complicated. You don't have to know all the problems that you could have or a patient might have or concerns. All you need to know is what theirs are, and you can simply find that out by asking the question. So the team-based care is obviously very important. We do work with physicians very closely. We're trying to, I'll show you in the next slide here how that's we're trying to improve on that. But we need to overcome the emotional barriers, and I think that's not only on the patient's part. And the psychological care for people with diabetes, I think there's still a gap there too. There's a lot of work done by Dawn at the Diabetes Attitudes and Wishes and Needs study that was done, international study, over 5,000 or more patients involved. with that, but it really reflected exactly the problems that we've discovered here too. So this is our attempt at the new referral form. I know it doesn't probably make much sense to you if you haven't seen the old one first, but what's on the right is all the sort of services required, and that's expanded to include the medications review consultation. Let me just bring that up, a little bit of a highlight. So that's the new bit. In the old referral, we had gestational information over there for the gestational clinic, so it wasn't really relevant to our clinic. So what we've done is we've captured a little bit more the risk factors, just to identify patients at higher risk, a little bit more information about those who are discharged from hospital, so that helps us triage them more appropriately because many things change after hospitalization. We need to see them more quickly. There's new injection hormones, GLP-1s, that are on here now too, so that prompts physicians as a reminder that, oh, there's another option here to insulin. And then the big thing was like, if you look on the italicized part in brackets under medication review, it's recommendations will be returned to referring healthcare provider by the CDE, the Certified Diabetes Educator. So it's kind of like a reverse prescription in a way, meaning that you're not really sure what this patient might want to do or what they can afford, or I'm not really sure myself because there's so many options now with diabetes. Send them our way for, let's go over what the options might be with that patient, find the best choice, send that back on a referral letter or even a prescription tool they'll show you, and hopefully that will help speed up that process, perhaps finding the best therapy for the right patient. So that's kind of where we're trying to go with this. So we've expanded the options of insulin orders in there to prompt again prescribers that there are different choices, because we're not seeing a lot of intensification of insulin, meaning adding mealtime either yet. So just providing some more cues there. So we're yet to figure out what the feedback is going to be like on that. That's going to be the focus of the next research project. This is a prescription tool that was done from Diabetes Canada. It's a little busy, and we had some initial feedback that it was overwhelming, but what we would do on this one, if we're going to do this, is to fill it in for the physician, and they can look at that and then send that back, and then it's a prescription and a referral letter as well. So that's the hope anyway. So the hopeful outcome here is to really receive individualized treatment recommendations, or for the physician too, that way, because diabetes is largely individualized treatment for all patients in terms of both therapy and guidelines. The real focus is to reduce the delay in starting and intensifying treatment, and really for us, what we see on a daily basis is trying to reduce some of that unnecessary psychological burden that patients are living with for years before treatment is actually initiated. So this was just a post sort of review of the study, and this is just looking at the Jubilee population, like what we had, our 20 patients here. Our A1C at initiation was 9.6, so a little better than the overall island-wide one, but very similar to Harris's trial. And I did go back, so this is where I kind of ran into I'm not sure what they call that, a violation of the protocol perhaps, opened up the patient's labs, and because I wanted to verify, what was going on in this initial trial, so I had to redo the protocol and get that cleared up before I could do it forward, which I did. And anyway, they were pretty accurate. So the stated years above target was, about 2.7 years. So I broke it down two ways: the years above the A1C target, which for most patients is 7% in most places in the world. So that was about 3 years above 7%. For most patients, and above 8.5% is just over a year. So the 8.5 trigger point is sort of the A1C when a patient shows up, a brand new diagnosed patient, where a physician could consider insulin. It's not when you start insulin. It's just if you just see someone you haven't seen before and their A1C is that high, you could do insulin. But I think that gets misinterpreted. So often we're waiting because we think you have to wait. For example, I had a couple of residents in the room a few weeks back, and I said to them, well, if you were starting a patient on insulin, what A1C would you wait for before you would do that? And they said, 9, which is right on. I did a kind of a casual assessment of some physicians at a CME event up in Bear Mountain. There was about 40 in the room, and I asked them that as well. I said, and actually I turned it around a little bit. I said, what would your A1C have to be before you started insulin? And again, many were 9%. So I said to these two residents in my room, I said, okay, well, why 9? And they said, well, that's when you start getting real significant organ damage above 9. Like, so you're waiting for that to happen before you start insulin? They're like, good point. So I said, what is the target for A1C for most people with diabetes? They said 7. So I said, what is happening between 7 and 9? Like, I don't know. so this is kind of where we're going. So anyway, this was sort of the Harris' study's A1C improvement. So this is at 79 patients in Ontario. They started at 9.5. Year 1.2, they were down to 8.1, and by 3.8 years, they're down to 7.9. His point was, insulin was started too late and intensified too slowly, and people were often still not under control. I think he had 20% still over 9% after 4 years, and this is just observational kind of study in a way in physician practice in Ontario. That was ours. So we somehow dropped people to 7.5 in about 1.2 years, and there was no intention to follow up. We didn't even know we were going to be looking at this. This was just looking back on the people who were in the study, and we actually had quite a significant drop in with the same start. So my theory is about that one is that because we unraveled some of that emotional issue behind insulin, I think patients were likely more compliant with therapy and were willing to kind of do what they needed to do. It would be interesting to track that longer, but I'd have to redo that whole protocol again. But that's a purpose for another study, which is this one. We haven't really got started this, but this is now a physician-focused project I'm waiting to get some grant money on. So this is going to be looking at just kind of like that question I had with those 2 residents in the office, like, what is your trigger point and why is it at that level? I think physicians are dealing with the same issues that our patients are dealing with, some misinformation about things. They might be thinking that, well, they'd probably be okay, it doesn't really matter, I don't know. But we want to find out. So this is going to be a kind of one-on-one, like, let's really dig into this issue and this topic at hand or question at hand and find out, like, what is the rationale behind that? What informs your decisions? What are your difficulties? How can we make this better, too? Because everyone has a landscape or a perspective on what they think insulin looks like or what diabetes is. And we see a lot of patients that they come back after they've been newly diagnosed and they're like, I've never felt better. I'm walking a bit more. I'm eating better. This is the wake-up call I needed. I'm actually quite happy that I've been diagnosed. It's actually quite impressive to hear that. And there's others who actually don't have a good time with diabetes and they have unfortunate issues happen. So it's not always a sunny, nice place to hang out. It can be a real burden on top of everything else that's happening in life. But some of that is actually misplaced and misinformed. So this is something I got from my wife, actually. She works this wasn't something she thought about me. This was more about her clients. My colleagues wondered about that. Like, was she referring to you when she said this? No, she works in specialized victim services with abused, not only women, but men, and counseling them around boundaries and safety and maybe sometimes how to change your behavior or relationships. But it's like with insulin, it's the same thing. I don't expect someone's going to start insulin when they come in the room. I just hope they will make the right decision. And so it isn't really my agenda. It is theirs, but I think they need to have the proper information to make that happen at the right time. So really it's patient-centered care. It's not very complicated. All right, any questions from the room or from the audience?